Welcome back. Our next speaker is Dr. Sara Bluestein. She is an allergist and immunologist at Atlanta Allergy and Asthma. She treats patients of all ages and has a particular interest in food and drug allergies, eczema hives, and she will be speaking to us today about eosinophilic asthma. There will not be a Q&A after this session, so any questions that you place in the chat, we will forward on to her to be answered later. Thank you and welcome, Dr. Bluestein.
Hi everyone, my name is Sara Bluestein. I am presenting here virtually from Atlanta Allergy and Asthma. Sorry that I couldn't be there in person. Today we're going to talk about eosinophilic asthma, updates on Pipeline Therapies. Here's where I am. I don't have any disclosures. Here's the objectives for today. While this screen is up, I just want to say thank you for inviting me to give this talk. It actually was really cool for me because I gave a similar talk in 2020, and since that time we have one new FDA-approved biologic for asthma, that's Tezspire or tezepelumab, that was approved in 2021. And then two of the biologics now have age 6 and up indication, and lots of new therapies in the pipeline, and that's just in 4 years. That's why I love being an allergist. Here's the outline for the presentation today. We're going to briefly review asthma pathophysiology, including T2 high versus low asthma, discuss biologics that are out, and focus on severe asthma and what else can we target looking ahead. No, there's not one clear diagnosis of asthma, but it's a complex disease with variable airflow limitation and respiratory symptoms. Environmental and genetic factors both play a role. And then on top of that, you can have different triggers. Poor adherence, of course, is going to play a role. And then quality of life in terms of choosing treatment. Knowing all of this, we want to practice precision medicine and target each patient-specific endotype. So we'll focus on T2 high asthma, of course, today, since this is the eosinophilic type, but just to know that there's two types, we'll look at this now. T2 high asthma is eosinophilic asthma with cytokines including interleukin 4, 5, and 13. The biomarkers we're going to think about tracking when we're treating these patients is immunoglobulin E, eosinophils, and FeNO, which we're going to talk about in a second. In T2 high asthma, as a result of airway inflammation downstream of these cytokine pathways, we're going to get mucus overproduction and airway hyperresponsiveness. T2 high asthma includes 50% of asthmatics, but only 30 to 40% of severe asthmatics. T2 low asthma is non-eosinophilic. Cytokines are interleukin 6, 23, and TGF-beta, which then lead to regulatory T cell activation and release of interleukin 17. It's not a great biomarker, but induced sputum neutrophils is considered a biomarker. And the biggest thing to know is that the absence of these upregulated T2 pathways likely contribute to poor responsiveness to corticosteroids. It's more poorly understood, and as a result, there's limited treatment options. I just want to mention FeNO since we can track it as we treat patients. FeNO stands for fractional exhaled nitric oxide. Nitric oxide is a gas produced by cells involved in inflammation associated specifically with eosinophilic asthma. We measure it by parts per billion in air that is exhaled, and it helps determine eosinophilic inflammation. What it's most helpful for clinically is tracking effectiveness of medications in patients over time. How does all of this lead to asthma? Especially, let's focus now on T2 high asthma and allergen exposure. So once we have a dysregulated epithelial barrier here, when we've lost tight junctions, meaning things can get in more easily, we get an insult, right? Today we're going to be talking about allergens, but that insult could also be a viral trigger of someone's asthma or pollution, for example. This is going to set off alarmins, and here alarmins to focus on are TSLP, interleukin 25, and interleukin 33. Now first, TSLP, or first side of the pathway. TSLP is going to prime dendritic cells here to induce the differentiation of naive T cells into Th2 cells. Th2 cells then activate B cells through IL-4 to then differentiate into plasma cells that generate immunoglobulin E. Immunoglobulin E is required for mast cell responses to allergens. Then IL-25 and IL-33 are the other alarmins on this side of the pathway. They activate something called innate lymphoid cells type 2. They also activate mast cells, basophils, and eosinophils. Activated ILC2s, similar to Th2 cells, produce interleukin 5 and interleukin 13. Interleukin 5 is then what's going to promote eosinophil differentiation and survival in these airways. And IL-13 is well known for its effect on mucus production in asthmatic patients and in flares. All of these activations are going to lead to airway hyperresponsiveness, smooth muscle hypertrophy, and airway remodeling. Now let's talk about severe asthma specifically. Gina defines this as uncontrolled asthma despite adherence with maximal optimized therapy, treatment of contributory factors, and that it worsens when high-dose treatment is. So today we're going to focus on step 5 over here, specifically talking about severe asthma, but I just wanted to show the Gina stepwise asthma therapy approach from this year. They differ in track 1 in that steps 1 and 2 are combined using ICS formoterol as reliever to reduce risk of exacerbations compared with just short-acting beta agonist alone. And of course, it's a more simple regimen, theoretically increases adherence. And then here we have two separate step 1 and step 2, which is inhaled corticosteroid whenever SABA is started, and then step 2 here, low-dose maintenance ICS. So we're going to talk about biologic therapy now, focusing on these severe asthmatic patients who have failed all the way up until step 4, right? Quad AI defines biologic therapy as types of therapeutic treatment designed to specifically block or enhance a biological phenomenon, gene, or protein which is involved in a disease process. Here are the 6 FDA-approved biologics for asthma. Here's their target here in red. So we have anti-immunoglobulin E, that's omalizumab or Xolair. We have our anti-interleukin 5 therapies, mepolizumab or Nucala. We have reslizumab, Sincair. We also have anti-IL-5 receptor therapy, that's benralizumab or Fasenra. We have anti-interleukin 4 receptor alpha, which blocks interleukin 4 and 13. That's dupilumab or Dupixent. And then most recently, we have our anti-TSLP, which stands for thymic stromal lymphopoietin, and that's tezepelumab or Tezspire. So let's go one by one with each molecule or cytokine that we can target. So first, immunoglobulin E. In asthma, this is what we think of when we think about hypersensitivity reactions causing asthma flares. We have IgE here on the mast cells that when it's exposed to antigen or allergen, it recognizes it. These immunoglobulin E's cross-link, and then the mast cell essentially explodes and we release preformed mediators such as histamine, and that's going to lead to our symptoms of asthma. So we get increased mucus production, we get smooth muscle constriction, we get bronchial mucosal edema and inflammation. So here's omalizumab or Xolair. It was approved in 2003, so this is the first biologic approved for asthma. It is approved for patients 6 years and up with moderate to severe persistent allergic asthma who have aeroallergen sensitization, meaning that they have positive skin testing or positive IgE testing and blood work to inhalants. And it's also indicated for patients not well controlled by inhaled corticosteroids who also meet these other criteria. So again, the target is IgE. The way it works is it's directed against something called the epsilon 3 domain of IgE, and essentially we have a big bulky molecule there now, so it prevents the interaction with Fc epsilon R1, so that the IgE molecules cannot cross-link and cannot lead to release of the preformed mediators from the mast cell. Again, it's for allergic asthma. In 6 to 12 years, we're going to dose based on IgE levels from 30 to 1300, and 12 years and up, IgE levels 30 to 700. Again, weight-based dosing and IgE-based dosing for subcutaneous administration once a month. In studies, we know as an add-on therapy, it significantly reduces the rate of exacerbations and ED visits. It does carry a black box warning for anaphylaxis, and that's because in the pre-marketing clinical trials in patients with asthma, anaphylaxis was reported in about 3 of 3,500, which is about 0.1% of patients. So our patients on Xolair also carry EpiPens on the days of their shots. Other uses, so this is important because a lot of our atopic patients, right, are going to have another atopic disease, and we may want to use one biologic rather than two to target two disease processes. So Xolair or omalizumab is also approved for chronic idiopathic urticaria in those 12 years and up, for food allergy in those 1 year and up, and for chronic rhinosinusitis with nasal polyposis 18 and up. Now let's talk about these anti-IL-5 therapies. This or both of these are approved for patients with severe eosinophilic asthma who have frequent or continuous oral corticosteroid use, inadequate asthma control despite maximal inhaler therapy. In general, we know that eosinophilia is a predominant feature in at least 50% of asthmatic patients, and IL-5 is a key cytokine in this, responsible for the eosinophil differentiation, activation, and recruitment. Again, we have IL-5 here. Once it has been activated here by ILC2s, or excuse me, released by ILC2s once they're activated, or Th2 cells, then we're going to get eosinophil recruitment to the lung tissue, and that again is going to cause some of these symptoms. Each of the anti-IL-5 therapies are here. So mepolizumab or Nucala, it was approved in 2015. It's against IL-5. Singulair approved in 2016, also against IL-5. And then we have Fasenra or benralizumab approved in 2017. And this one is against the IL-5 receptor. Okay, so let's look at all of these together. We have mepolizumab or Nucala. We're going to go through this one first. It's approved for ages 6 and up. We give it subcutaneously, 100 milligrams every 4 weeks. The phenotype criteria in studies was severe eosinophilic asthmatic patients with greater than 150 EOs per microliter in the last 8 weeks, or greater than 300 at any point in the last 12 months. We know that the most common side effects of mepolizumab are headache, injection site reactions, which is common across all of them, and then herpes zoster possible risks. So I just wanted to touch on this because this is a common question that we get when we prescribe Nucala. In the clinical trials, 2 patients that were treated with Nucala and 0 of the placebo-treated patients developed shingles in the studies of about 1,300 patients. As a result of that, now the label states that physicians or clinicians should consider varicella vaccination in patients where they are of age before we're about to start, or they are immune suppressed. In general, there's no cause and effect explanation for the association with herpes zoster and IL-5 in general, or with Nucala specifically. Going back to studies of improvement in asthma symptoms, there is 53% reduction in exacerbations per year with Nucala versus placebo, and a 61% reduction in exacerbations per year requiring hospitalization or ED visits. Other uses for Nucala, we have chronic rhinosinusitis with nasal polyposis 18 and up. We have EGPA or eosinophilic granulomatosis with polyangiitis, 18 and up, or hypereosinophilic syndrome, 12 and up. It was studied in EoE, but it did not meet primary endpoints, and they are looking at it again with different endpoints and different measures. Reslizumab or Singulair is the next one we're going to talk about. It's approved in 18 and up. It's given IV, and as a result of that, I think just not used as often anymore. The dose and frequency is weight-based dosing every 4 weeks, And this, in studies, the phenotype criteria included severe eosinophilic asthma patients with 400 or more eosinophils per microliter within 4 weeks of starting therapy. For reslizumab, there also is a black box warning for anaphylaxis. It occurred during infusion in 0.3% of patients in the studies. Malignancy risk was also observed, again, small percentage of patients, with the main reported side effect being throat pain. And studies showed a 59% reduction in exacerbations. And sometimes in obese patients, we consider this biologic since it has weight-based dosing. And right now, there are no other indications for Syncare. Then we have benralizumab or Fasenra approved 6 and up. So that change happened in the last few years as well. It used to be only 12 and up. Route is subcutaneous. The dose is 30 milligrams, and this is given initially every 4 weeks for the first 3 doses, and then dosed at every 8-week intervals. The eosinophilic phenotype criteria includes severe eosinophilic asthma patients with over 150 eosinophils per microliter at the time of the visit or within the previous 6 to 12 weeks, or 300 or more eosinophils per microliter at any point in the last 12 months. Main reported side effects, headache and throat pain. Benralizumab is the only one that targets the interleukin-5 receptor rather than interleukin-5 itself, and as a result of that, there's enhanced eosinophil apoptosis through antibody-dependent cell-mediated cytotoxicity. And what that means is that we're killing cells that are expressing the IL-5 receptor alpha. That includes basophils. And so sometimes if a patient is not having great response to a biologic and their eosinophil count is still very high, that's a time to consider Fasenra as well. In studies, 51% reduction in exacerbations per year. There are no other indications currently, but in phase 3 data published in the New England Journal of Medicine in February of this year, the data suggests there's remission and an achievable goal for eGPA, so more to come with that. It did fail to meet primary endpoints in EoE trials to date, but although it has orphan drug designation for chronic rhinosinusitis with nasal polyps, the primary endpoints were met, but the FDA rejected the approval and requested additional clinical data. So now that has transformed into the ORCID trial, which is ongoing. The next target that we can block is interleukin-4 receptor alpha. So this class of drug blocks both interleukin-4 and interleukin-13 because they share a common interleukin-4 receptor alpha. Interleukin-4, blocking it is important because normally it promotes naive T cell differentiation down that Th2 pathway, which then downstream is going to induce B cell class switching to immunoglobulin E. And then blocking IL-13 is also important because normally it helps as well with IgE class switching, but also very involved in mucus production. And again, like we talked about earlier, leading to recruitment of eosinophils and basophils. IL-13, because of mucus production and these downstream effects, is involved in airway remodeling with smooth muscle and bronchial fibroblast proliferation. Our approved drug to block interleukin-4 receptor alpha is dupilumab or Dupixent. It was approved in 2018. It's approved for ages 6 and up with moderate to severe eosinophilic asthma. It blocks the IL-4 receptor alpha subunit, and this drug is dosed every other week or every 14 days. It does have warnings on the label for conjunctivitis and keratitis, especially when we're using it to treat atopic dermatitis or eczema. We know that in asthmatic patients, it temporarily increases eosinophils, so something to monitor there if they were very high to start. Although the most common side effects are going to be throat pain and again that eosinophilia. There is a warning to avoid use of live vaccines in patients on dupilumab, and there are current studies ongoing to give recommendations of when and how long to be off of Dupixent before getting live viral vaccines. Other uses are eczema or atopic dermatitis, 6 months and up, chronic rhinosinusitis with nasal polyposis, 18 years and up, EOE, 1 year and older, and then also for prurigo nodularis, 18 and up. The final cytokine with approval or with an approved drug where we're able to block it is TSLP. TSLP is released by airway epithelial cells in response to allergens. Remember when we were talking about the alarmins. Activated TSLP then triggers downstream pathways, the eosinophilic pathway, leading to production of IgE through class switching, and then also the mast cell pathway, leading to airway inflammation and hyperresponsiveness. Tezspire was approved in 2021. Again, it blocks TSLP, and we use it in ages 12 and up with severe asthma. It's dosed at every 4 weeks and given sub-Q. Studies showed up to 71% reduction in exacerbations, and most common side effects are pharyngitis and arthralgias. Now that we've discussed these 6 biologics, let's take a look at how they are affecting patient outcomes and biomarkers we can track. We know that in general, when we block IL-5 specifically and target that axis, we're going to more reliably decrease the frequency of asthma exacerbations than in some of the other drugs, although Tezspire here can compete. Dupixent we know is going to have at least initially a transient increase in eosinophilia, and then Xolair is not going to have as strong of effect on the eosinophils. Pheno, again, something we can track in the office and not have to rely on blood work. We're going to see decreases with Xolair, with Dupixent, and with Tezspire. Serum IgE, we're going to most affect with omalizumab or Xolair. All of them have great effect on decreasing asthma exacerbations and improving FEV1. And this is what we track with pulmonary function testing. Then we talk about symptom scores. If we can decrease asthma symptom scores, we can improve quality of life. The only last thing to mention here at the bottom is that Xolair specifically, there was more equivocal or less exciting evidence for oral corticosteroid sparing effect, although we do know that patients are able to come off, but just further into therapy. Again here, not to beat this to the ground, but I'm projecting my own horizontal learning to everyone. This is just showing each FDA-approved biologic for asthma up here at the top and everything it's indicated for down below. So one thing just to mention, it separates out in this article allergic asthma, which is criteria for omalizumab with IgE predominance, eosinophilic asthma involving interleukins 5, 4, and 13, and then Tezspire, which does not have a specific eosinophilic or IgE designation, does not have to be allergic asthma, so just categorized for severe asthma here. Okay, so I think this is probably the most exciting part and what everyone is kind of ready to hear more about. So let's talk about the future. We want the most personalized medicine for better treatment of specific endotypes and phenotypes for each patient. To date, of course, there's not head-to-head trials comparing the anti-IL-5s or each of the different categories. While there are meta-analyses, no direct head-to-head trials, right? There are some advantages of each, given dosing frequency, how it's given, but nothing directly about efficacy. And then we have new therapies. We're going to continue to explore these different biomarkers and other potential targets for therapy. So far in trying to replicate blocking IgE, these biologics have not shown similar clinical efficacy to Xolair, although they were better than placebo. So as a result of not outperforming Xolair, they have not been able to be approved or to keep up. So here, dupilumab, I'm not exactly sure if that's the right way to say it, to be honest. This one is one of the more exciting ones for me in the pipeline right now. It's an anti-IL-5. In phase 3 trials for severe eosinophilic asthma with eosinophil counts over 150 per microliter, it is an ultra long-acting monoclonal antibody with a 6-month dosing schedule. So that would be just 2 injections per year. That's pretty cool. So far, it has met its primary endpoints of reduction in annual exacerbations without significant adverse events, and it's expected to finish phase 3 trials early next year. We've also tried to block interleukin 4 and 13 with other drugs other than Dupixent. Clinical trials blocking IL-13 alone have not been effective. We have tralokinumab and lebrikizumab, which are also anti-IL-13, and those were also not effective. Anakinzumab trials halted in phase 2, again blocking just IL-13. And what this is indicating for us is that Dupixent, which is a great drug, right? We know that this supports the need to block both IL-4 and 13 to achieve positive outcomes in severe asthma. So far here with anti-TSLP, this is actually in an inhaled form. Phase 1 has shown good safety data, but definitely more to come. This lunsekimig, this one is a nanobody that inhibits both TSLP and IL-13, and again, good safety data so far, but still in phase 1 trials. Let's talk about a new target, IL-33 or interleukin 33. If you remember from an earlier slide, this is one of the alarmins that is going to get released when the epithelial cell layer is damaged. It's going to act on all of these cells here, eosinophils, mast cells, Th2 cells, and basophils to induce release of pro-inflammatory cytokines. I want to mention also here soluble ST2. So ST2 is the IL-33 receptor, and soluble ST2 binds to IL-33 as a decoy receptor and prevents its activity. So this is potentially two targets for us to look at in asthma treatment. So targeting anything in this pathway and interfering with binding of IL-33 to ST2 and thus affecting downstream signaling will then decrease the inflammation contributing to the disease process in asthma. So here, itepekimab is in early phases for asthma, but in phase 2A and 3 for COPD, that's an anti-IL-33. And tozorakimab is an anti-33 in phase 2 trials. I also wanted to mention masitinib. This is an oral tyrosine kinase inhibitor that targets c-KIT, which is on mast cells, and platelet-derived growth factor, which is on bronchial cells. In phase 3, it met primary endpoints for severe uncontrolled eosinophilic asthma, and they're calling uncontrolled meaning unresponsive to high-dose ICS. In this arm of the study, that decreased exacerbations by 29%. But in more severe uncontrolled asthmatics who were unresponsive to high-dose ICS-LABA or to oral corticosteroids, decreased exacerbations by 35%. So a little bit less effective than some of the ones we were talking about, which are between 50 and 75% in general. However, this is potentially an oral option for patients. So now what, right? We have a severe asthmatic patient. We've started a biologic. How long does someone need to stay on it? When can we step it down? What do we do if someone doesn't respond? GINA guidelines recommend an initial evaluation in 4 months after starting a biologic to assess efficacy. If great response, of course, we're going to continue and follow the patient. If no response at the 4-month mark, that's when we're going to consider an alternative biologic. If the response is unclear, we're going to continue the trial for another 6 to 12 months. It's important to monitor spirometry and track FEV1 to see improvement in lung function every year or 2. We know some biologics have faster improvement in FEV1, such as Dupixent, than the others. Of course, the first goal is going to be to taper off oral corticosteroids if the patient is on them. Angina guidelines recommend reducing inhaler therapy every 3 to 6 months to a minimum baseline treatment with a medium dose ICS. So far, there's no studies to suggest asthma remission or improvements in airway remodeling with biologic use. So if a patient wants to trial off, expert consensus suggests not considering that for at least 12 months in patients who have responded to biologic therapy. If a patient fails to show benefit or only partial benefit after starting an anti-IL-5, then we're going to consider checking eosinophils to determine if counts have been sufficiently suppressed. Persistently high eosinophils may indicate treatment failure. That's when, if a patient, we feel the best drug is an anti-IL-5. If they're not already on Fasenra at that point, that's when we're going to consider Fasenra, since it was shown to more completely deplete eosinophils by blocking the IL-5 receptor. And then again, although indicated for eosinophilic asthma, worsening eosinophilia has been seen after starting Dupixent, despite overall improvement of symptoms. And if that eosinophil count is getting too high and we're worried about other organ damage, then we're going to switch biologics. Here are my references, and I hope that you guys enjoy the rest of your weekend.
Well, thank you, Dr. Bluestein, for an excellent talk on eosinophilic asthma. We appreciate you sharing your time and expertise with us today. We're going on a 15-minute break. When we come back, we are going to hear from Dr. Corey on eosinophilic fasciitis.